that written. And I sent him a copy of this article from the British Journal of Radiology so he could review it. This is a very nice article published in 1977 from the British Journal of Radiology, reviewing various cases of water-soluble contrast myelography and indicating the fact that it is possible to have a water contrast myelogram and have adhesive arachnoiditis. In all fairness, the incidence of that is very small. Typically, the complications of water-soluble contrast myelography are not the chronic complications of adhesive arachnoiditis, but they typically have to do with the acute neurotoxicity of these agents on the nervous system. These are the problems that the radiologist gets to see. The radiologist has never seen the complications of Myodil or pantopaque myelography. The radiologist has never seen the complications of thorium dioxide thorotrast because he simply does the study. These are toxic agents that produce problems over a period of time. I think it's really important to point out that there was a country in Europe that did catch on to all of this quite early. There was a country in Europe which in 1940 said, wait a minute, thorotrast is radioactive. It should not be used in people. The clinicians said, we're not going to use it anymore. It's the same country and the same group of people who in 1948 said, wait a minute, iofenolate is toxic. There are problems with its use. We're not going to use it anymore. They were the ones who started to develop water-soluble myelography as an alternative. And it wasn't the United States who was concerned, and it wasn't the UK, it was Sweden. The Swedish physicians showed a much higher awareness, concern, and they indeed published these observations. Not a lot of people paid attention. Let's look at some of the things that were published in 1944 in this article, which is the primary article upon which these substances then came to be used in clinical use. This is from the original article, and these are sections of the spinal cord in experimental animals, dogs, in which Myodil and pantopaque were introduced as a scientific study to see if there were any side effects. In this slide here, one is looking at Myodil. There is severe adhesive arachnoiditis. There is degeneration of the spinal cord with cystic degeneration. This is the animal with pantopaque. There is adhesive arachnoiditis, degeneration of the spinal cord, myelopathy of the spinal cord, and cystic degeneration. Now, this is the animal with pantopaque, and this is the animal with Myodil. I think you can see that there's less of a reaction with pantopaque than there was with Myodil. The conclusion reached in this article, and this is from the article, it says, with the assurance from these experimental studies that the new medium was safe, it was first tested clinically on November 23rd, 1940. There's no evidence from their own material that was published that this was safe. Purely and simply, if you read the article, if you look at their illustrations, it was toxic. It is incredible how anybody can look at that and say it was safe. It was not then, and it was not subsequently. In 1969, the manufacturers of Pantapaque did another scientific study on animals and dogs. Those are the only two studies that have ever been done, to my knowledge, testing the toxicity of these substances. Now, you must recognize that the use of experimental animals, dogs, mice, has been the standard in the past for determining toxicity. And to my knowledge today, all of the iofentalate toxicity studies performed on experimental animals showed adhesive arachnoiditis in every single case. All of the experimental evidence. Given this information, why would anyone reasonably expect that Pantapaque or Myodil was safe in humans? Because this is the background of information. Pantapaque actually was originally intended to be used for myelography to show if there were any blocks in the spinal canal. And the original intent was to introduce a very small few droplets of Pantapaque in the cervical area and observe to see where they stopped, so that neurosurgeons and other clinicians could see where there was a block in the spinal canal from a tumor or other problem. As a matter of fact, it was never intended for use in full column myelography. And how it came to be used routinely in the United States for 450,000 cases a year, and gosh knows how many in Europe for almost 5 decades, is a complete mystery to me. I don't understand it. And if somebody does understand it and can explain it to me, I'd really like to know that. It was in the 1970s that we really were wondering about Pantapaque. And one day, I put some Pantapaque in a styrofoam drinking cup, right here. 24 hours later, this is what the styrofoam drinking cup looked like. The Pantapaque actually dissolved the styrofoam. Now, people have said to me, Dr. Burton, that's dirty pool. The subarachnoid space isn't styrofoam. That's true. I'll be the first to admit it. But styrofoam is an inert organic molecule. Wouldn't you think that anything that can do something like that, styrofoam, probably should be looked at very carefully before it's put into the subarachnoid space? There is a lot of other evidence of iofentalate dissolving other inert substances. I'm just throwing this out to you from the standpoint of incidental interest because it impressed me at the time. Pantapaque is a substance that is very slowly absorbed from the subarachnoid space. And I will just show you some plain x-rays of patients who had Pantapaque myelograms done 10 to 15 years previously, where there is still visible Pantapaque in the spinal canal and visible Pantapaque in the cisterns around the base of the brain. This might be a good time to stop in this presentation and show you a video which is was specifically created to give a better understanding of what we have been discussing so far, the nature of the subarachnoid space, the nature of myelography, and the type of reaction that typically occurs in the subarachnoid space following oil myelography. My name is Charles Burton. I'm a neurosurgeon and I'm a specialist in spine care. I've worked in this area over the past 25 years. Since 1981, I have been medical director of the Institute for Low Back Care located in Minneapolis, Minnesota. The Institute for Low Back Care is an organization that specializes in the rehabilitation of complex back problems. Adhesive arachnoiditis is a complex spine challenge. It is an international, ethical, and medical challenge. This is an example of adhesive arachnoiditis as shown on an oil myelogram. The characteristic pattern and irregularity can also be seen on other studies, such as this enhanced CT scan. The arrow shows residual droplets of oil. This is an MRI scan showing the severe changes of the cauda equina produced by this oil substance. In this animation, we will explore the normal anatomy of the spinal column, the process of myelography, and the introduction of a foreign body substance into the subarachnoid space. Shown here are the various components of the spinal column. We will focus on the lumbar area. Basically, the vertebrae are separated by tough collagenous washers called discs. On the left-hand side are the facet joints, and the vertebral processes are shown. This sagittal view allows us to appreciate the spinal canal filled with nerve roots called the cauda equina. The cauda equina represents the continuation of the nerves of the spinal cord, which actually ends at approximately the L1, L2 area. We are now looking at an enlarged segment of the spinal canal with the various membranes covering and surrounding the spinal nerves. On the outside is the thickest membrane called the dura mater. Next to it is a thinner membrane called the arachnoid membrane. The pia mater is a very fine membrane surrounding each nerve, and one sees the nerves themselves. The subarachnoid space normally contains spinal fluid. Extending from the arachnoid membrane are fine filamentous threads called trabeculi. These cross from the arachnoid to the pial membrane. The spinal fluid is produced through the arachnoid membrane, circulates around the spinal nerves, the spinal cord, and then to the brain, where it is absorbed. The finest membrane is the pia. The next finest membrane is the arachnoid, shown here in close-up. It consists of a mesh of interwoven collagen fibrils, much like tissue paper would appear under a microscope. We are now going to see the introduction of a myelographic agent through a needle placed in the lumbar spine for the purposes of myelography. This is called a lumbar puncture. The needle is placed between the vertebrae, puncturing the dura and the arachnoid membrane, and the foreign substance is then injected into the subarachnoid space. Shown here is a material which is a oil contrast agent. This is hyperbaric. It has greater density than spinal fluid and moves downward depending on how the patient is positioned. The myelogram is therefore performed by tilting the patient up and tilting the patient down and taking fluoroscopic or X-ray pictures of this process. In this case, the dye is moving into the thoracic area. One can extend the dye into the cervical area. Sometimes dye escapes into the basilar cisterns of the subarachnoid space around the base of the brain. This is a close-up of the needle in place through the dura and arachnoid. The spinal fluid has been replaced by the contrast media, which in this case is an oil contrast media. Shown here is the filling of the interstices of this arachnoid membrane by the foreign body substance, the oil myelographic agent. The presence of this foreign body begins to initiate a secondary response, which is a normal inflammatory response to a foreign body. Following oil myelography, typically, attempts are made to remove this substance. But even after what is referred to as a successful dye removal, there is significant residual dye material trapped in the interstices of the subarachnoid space. These micro portions of dye are present in all patients. There can be microglobules, and there can be residual microcolumns of dye. But typically, there is at least significant dye microscopically left in the subarachnoid space. The reaction or influence of the dye promotes a secondary response. This is an inflammatory response. Initially composed of white blood cells, leukocytes, mesenchymal cells, and macrophages. These are the cells that ingest or attempt to ingest foreign bodies. As the cellular response progresses, the mesenchymal cells transform themselves into fibroblasts. These are the cells that form collagen and form scar tissue. Scar tissue is, in fact, collagen. The first stage of the inflammatory process causes the spinal nerves to become enlarged and swollen, as shown here. In addition to the swelling of the nerves, there is distension of the adjacent blood vessels, which become hyperemic. As the nerves swell, the subarachnoid space actually disappears. And very typically, the spinal fluid is squeezed out from in between the spinal nerves. The limitation of this is the dural sac itself. As time progresses, the second stage begins, and this is of nerve atrophy. Scarring begins to increase, and the production of collagen fibrils by the fibroblasts produces scar tissue, which causes the nerves to adhere not only to each other, but directly to the arachnoid and to the dura. This animation shows the progression of this atrophy with production of less hyperemia, with diminishing size of the distended local blood vessels, and increasing amounts of scar tissue. You will note the scar tissue tends to envelop not only the nerve roots, but any foreign body droplets that are attached and held in place. As the scar tissue continues to be deposited, the nerves become more adherent to each other, and you will notice that they almost become part of the wall of the thecal sac. The thecal sac refers to the various layers of the dura and the arachnoid. The progression of scar tissue can be such that if one enters this dural cavity, one cannot recognize normal nerves. A lumbar puncture in a case like this can actually sever a spinal nerve because it is held fixed and cannot float away from the needle once it is placed. Various patterns of scar tissue can be formed. These can be appreciated on imaging studies, particularly MRI. Next illustrated is the mechanism of severe and constant pain in clinically significant cases of adhesive arachnoiditis. Normally, pain impulses travel to the brain by way of the dorsal root ganglia of the spinal nerve. Nociceptive impulses pass from the dorsal root ganglia up the spinal pathways to the brain itself, where pain is appreciated. When a normal dorsal root ganglia is stimulated, as shown here in a laboratory setting where a pig hair is being used, the stimulation of a normal dorsal root ganglion results in a short, quick pain impulse which is self-limited. The situation is very different if the inflamed dorsal root ganglion is stimulated in a similar manner. There is not a short, self-limited impulse, but continued, long nociception constantly being produced by the dorsal root ganglion to the brain. Inflamed dorsal root ganglia are so hypersensitive that even body movements, such as breathing, can elicit a continuing train of impulses to the brain. We will now observe actual operative photographs of the various stages of adhesive arachnoiditis. The view of the first stage shows the nerves to be swollen, obliterating the spinal fluid within the dural sac. The second stage shows progression of scar with the nerves adherent to each other and to the dura, and the third phase shows such severe scarring that opening up the dura appears to be an empty cavity because of the extensive scarring. If the scar tissue begins to calcify, it can produce a condition shown here, calcific arachnoiditis, which can produce progressive squeezing of the nerves leading to impairment of bowel or bladder function. Although adhesive arachnoiditis can be produced by exposure to different toxic agents, there is no question but that over the past 50 years throughout the world, the primary cause of clinically significant adhesive arachnoiditis has been the presence of iofendolate in the subarachnoid space as a means of diagnostic myelography. Any invasive myelogram is capable of producing serious complications of some sort. Iofendolate, however, has been unique in this regard over the years. The disease-produced adhesive arachnoiditis can be a very cruel disease. This has been and continues to be a worldwide problem. This entity has been a difficult process to understand. Thank you. Why do only some cases of severe adhesive arachnoiditis show severe pain, progressive neurologic deficit, or death? There are many people who have anatomically adhesive arachnoiditis who do not have clinical problems. There are no statistics or scientific studies that have been done to help explain why these things occur to some people and not to others, and why some people have clinical symptoms where others do not. The thing that we're very clear about is that the type of disease process that's produced is a very cruel disease. It's not something that goes away. It's there forever, typically. The patients have severe and incapacitating pain that is constant. It is disabling. It is unrelenting. The human body does not deal with that type of pain very well. In fact, the type of pain is a form of agony, not really pain. And this is hard to clarify because it is a form of a condition called causalgia. Causalgia is the type of pain experienced when there is a partial injury to a peripheral nerve, not a complete injury. The term was stated originally by a neurologist, Dr. Weir Mitchell, who was a Philadelphia neurologist who was a surgeon in the U.S. Civil War, the North against the South. And there were, during that period of time, hundreds of thousands of horrible maiming injuries to extremities, point-blank cannon firing at marching ranks of thousands of people. The casualties were tremendous. And he recognized that the type of pain that individuals experience from partial nerve injury was different from the usual type of pain, and the word causalgia was coined by him to explain this.